Hey there, micro friends. Welcome to another episode of Let's Talk Micro. As always, I'm so happy that you're here with me. And if this is the first time you're listening to Let's Talk Micro, well, thank you for choosing it as one of your podcasts. Okay, so I know you want to learn about tick-borne diseases, so I'll be brief. In this episode, I am joined by Dr. Kyle Rodino. And in the episode, he goes over different tick-borne diseases. He talks about test selection, he talks about timing. Overall, this is such a great introductory episode, so I hope you enjoy it. Let's go ahead and listen to it. Hey there, micro friends. Welcome to another episode. And I thought this time, we've been doing a lot of diagnostic testing. We've been doing a lot of rapid AST, and normally we focus a lot on bacteria. And I thought it would be great to do an episode a little bit different. And today we're talking about tick-borne diseases. And with me, I have a guest for that. And maybe, you definitely, if you're in the microbiology community, you're familiar with him. Maybe if you've seen the famous Battle of the Brains at ASM, you know his name. So it is great. We kind of met before a little bit, and it is great to have him on the podcast. So with me today, I have Dr. Kyle Rodino. Dr. Rodino, welcome to Let's Talk Micro.
Thank you so much for having me. I'm really happy you referenced the Battle of the Brains. It's such a fun event at Microbe every year, and it's a lot of work to kick it off, but it's so enjoyable to do that trivia with everybody.
Yeah, no, definitely. And one thing that I was talking to Chris Dorn about this when I had him on. Because I participated, and one of the things that I came out for my first time, and I kind of wasn't in the audience before, but the questions can be very like high level or very tough. And one of the things that he said is like, well, you try to make it fun and things like that, but you're also trying to come out and learn things. So the questions are definitely hard. So the first time I came out knowing, it's like, man, like this is so tough, like some of these questions, but other people they agree with that and they're like, yeah, no, they are hard. So but at the end, we all learn something. So it's a great event, very fun. So if you go to ASM, definitely attend it. Okay. So let's start, let's talk micro. We always like to do like a quick introduction where the guests kind of introduce themselves as to what they do. So in your case, maybe you can start with that and share a little bit of what sparked your interest in tick-borne diseases along with that.
Yeah, great, sure. So currently, I'm assistant professor in pathology and laboratory medicine at the University of Pennsylvania. I'm the assistant director of microbiology, which is sort of the traditional microbiology lab. And then I direct what we call the Rittenhouse Molecular Laboratory, which is a molecular infectious diseases laboratory that just started about 3 years ago, converted from a high throughput COVID testing molecular lab. And now we've expanded that into the future of molecular diagnostics here. I have a fairly long pathway to this current role. I learned about medical microbiology in a freshman seminar at the University of North Carolina. It was incredibly fortuitous opportunity where Dr. Peter Gilligan, who used to be the director of the microbiology lab at UNC Hospitals, he taught this freshman seminar something like twice in his decades-long career, and I was lucky enough to join it. And I was like completely fascinated by it first semester, freshman year of college. And then I left it all behind after that semester and kind of thought like that was really interesting, but I don't really know how to do anything with that. And then maybe 3 years later, I was thinking, I don't think I want to go to medical school anymore. I really loved the lab diagnostics part and microbiology. And I sort of randomly reconnected with him looking to do some undergraduate research. And that led me to do research for UNC Hospital in the micro lab for the rest of my time as an undergrad. I switched my major to medical laboratory science. When I finished up with that, I really wanted a break from academics and school, and so I took a job as a medical laboratory scientist in microbiology again. I just transitioned from the research to the clinical side. And I worked for UNC Hospitals in the micro lab for about 4.5 years, which was one of the best times of my life, learning and working and really enjoying what I was doing. But ultimately, I got to a point where I wanted the opportunity to direct a lab like that. I wanted to stay involved in medical microbiology, but on a different level. And so I went back to graduate school solely for the purpose to go then do a fellowship. So I did my graduate work at Virginia Commonwealth University School of Medicine, and then I went to Mayo Clinic for my CPEP fellowship, and then 2 years after that landed here mid pandemic at Penn. So that's the pathway. How did I become interested in tick-borne diseases? I think the beginning of me really understanding that was as a medical laboratory scientist at UNC. I had this very interesting role where I worked in like the processing area for a few years, and then I moved into this hybrid microbiology, immunology position, and I kind of got to do like everything that was in that lab. And one of the things I did when I was in my weeks in immunology was Ehrlichia antibody testing. And I can't say that at the time I really understood Ehrlichia and the diagnostic options, but I knew how to do that test. So that's like the first time I remember tick-borne diseases in the clinical sense. By accident, I did my PhD in vector-borne diseases. So when I went to Virginia Commonwealth, I studied Orientia susugumushi, which is a mite-borne pathogen in the Rickettsia family that's mostly found in the Southeast Asia sort of area. But the other side of our lab was an anaplasma lab, and I did some projects on there as well. So I really got into vector-borne diseases as a graduate student. Which parlayed great into going to Mayo for a fellowship to work with Bobby Pritt on more vector-borne. And so it's just sort of snowballed after that. And they're so fascinating. And it's, pathogens that are sort of underserved, under-recognized, limited diagnostics, complexity, and how you work it up. So I just think it's fascinating now. And now it just continues to build.
Perfect. Thank you for that, and definitely for the audience, and shout out to all the CPEP fellows out there, which are always great friends of the podcast and listeners. So hello there, and also hi, shout out to Dr. Britt as well. I had the chance to have her twice on the podcast. She's great. Okay, so let's go ahead and start with some basics here. So maybe for the listeners, maybe we can start giving them like a general overview of the major tick-borne diseases found in North America today.
Yeah, sure. There's a lot of them, and you could organize them in a bunch of different ways. But I'm going to organize them by, bacteria, parasites, viruses, and give sort of the connections as we go through. So, if we start with the bacteria, the Borrelia make up the largest group, and of course, Borrelia burgdorferi and Borrelia mayonii, which both cause Lyme disease, are the most common of the tick-borne pathogens in the U.S. They are transmitted by Ixodes ticks, Ixodes scapularis, in most of the country, the East Coast, the central sort of area, and then Ixodes pacificus out in the West Coast. And these are mostly found in New England, the upper Midwest, and then, as I mentioned, the Pacific coast. So next in the Borrelias is Borrelia miyamotoi. Not a Lyme disease causing Borrelia, causes a relapsing fever type syndrome. But is also found in the same tick, the Ixodes tick, also in New England and the upper Midwest. So some overlap there in sort of the same genus, but different, really clinical syndrome, and also the same tick. We'll talk about Ixodes a lot. And then in the Borrelia group, the last sort of not as common, but found in the U.S., the real relapsing fever Borrelia. So Borrelia hermsii, Borrelia trichote. These are transmitted, though, by a totally different type of tick. So these are transmitted by soft ticks in the genus Ornithodorus. And really, these are found like in the Rockies and like the west and central parts of the country, usually like very rural elevation type areas. And then continuing in the bacteria, some of the rickettsial order pathogens. So Anaplasma phagocytophilum, transmitted by Ixodes scapularis or pacificus, again overlapping in the Northeast and the upper Midwest. A bunch of Ehrlichia. So Ehrlichia chaffiensis, most commonly are notable, Ehrlichia ewingii, a very uncommon Ehrlichia muris oclarensis. But most of these, the bigger ones, transmitted by Amblyomma americanum, and we find Ehrlichia more so in the southeast and the south central parts of the country, although we'll talk that's sort of shifting and changing all the time. And then the Rickettsia organisms. So Rickettsia most notably transmitted by dermacenter ticks. or rhincephalus ticks in the southwest. But this is really rickettsia in the sense of Rocky Mountain spotted fever is found in the southeast, central part of the country, and then sort of areas of Arizona, New Mexico. Shifting off of the bacteria to parasites. So, really, the main parasite transmitted by ticks is Babesia. And there are a few different species, but mostly dominated in the US by Babesia microti, in the Northeast and Upper Midwest, again transmitted by Ixodes scapularis. I think that's the fourth pathogen I've named that can be transmitted by that tick. And then Babesia duncani, which is really on the West Coast, by a dermacentor tick. And then lastly, the groups of viruses, which are relatively uncommon compared to the other organisms we discussed, at least for human infection that we recognize and diagnose. But most commonly in the group, Powassan virus, which is a flavivirus with two lineages. This is transmitted by Ixodes ticks again, mostly Ixodes scapularis, but the lineage 1 version of Powassan transmitted by Ixodes cookii, which is a less common human biting Ixodes in the Northeast and Upper Midwest. And then rarely things like heartland virus or bourbon virus, and just a couple arboviruses, both more in the central United States area.
Thank you for that. That was so wonderfully organized. Appreciate that. And for the listeners throughout this episode, I'm also gonna be referring. There was a mini review that you worked on along with I see with Bobby Preed and Ellie Thiel, and which is called "Update on North American Tick-Borne Diseases and How to Diagnose Them." And this was published in the American Society for Microbiology. For the listeners, I will put a link on the show notes so you can access it after you listen to the episode and read it in more detail. So when you hear me talking about a referencing an article, that's what I'm talking about. Okay. So from that publication, there's it highlights that tick species, they're expanding into new regions across the U.S. So how is this affecting, the epidemiology of tick-borne diseases, and what does that mean for diagnostic testing?
Yeah, we are seeing changes in the geography of ticks, and then of course the diseases that they carry. What does it mean? It really means that you might have new tick species in a region in which they were not previously recognized, because of that, the epidemiology of the diseases they transmit changes. Um, there's the potential for people to be exposed to pathogens that historically they would not have come in contact with if they were from a particular geographic regions. What it means diagnostically, I think, is that people just need to be more aware of what things are local, and maybe we need to just have a like the article suggests, a little bit of an update every once in a while on what is local. I think the other thing is that people travel so much and they're exposed in other parts of the country that, I mean, really, you just need to have a general understanding of what are the main pathogens and exposure risks in all parts of the country when you're considering what a patient might have. But that's really it. Is that it's affecting, and then in a sense of like people need to stay updated and continue to sort of think of what could be changing and what new pathogens might people be exposed to that in the past we wouldn't have considered.
Yeah, definitely right. And one thing we have learned, we're so with travel and everything, we're so connected, so we can definitely see things that are not normally seen in some places and things like that. Okay. So throughout this episode, we'll be talking about testing, diagnostics testing. But before that, can we talk a little bit about, like clinical signs and symptoms, that maybe, or patient history, we just mentioned travel, that should prompt clinicians to suspect a tick-borne infection?
Yeah, this is one of the challenges I think with tick-borne disease diagnostics is they all sort of look like each other in presentation, and they also overlap with things that are not infectious or not tick-borne, and so it's tough. There's few of these pathogens that have something really unique or pathognomonic about them that would key a clinician. We'll talk about that, but for the most part, they present with fever, headache, muscle and joint pains. That can be variable across the exact organism we're talking about, particularly fever and its persistence or recurrence, etc. But they look, people describe them as summer febrile non-differentiated illnesses. They're very nondescript in their presentation. Sometimes they have rashes, like in the case of Lyme disease. The rash is very well known, right? And that appearance can be very specific and helpful. And the just that simple recognition by a clinician can really narrow what might be the cause. But sometimes the rashes are variable or, again, nondescript, and they may or may not be present. Some of the pathogens have an appearance of what's called an eschar, specifically the spotted fever group Rickettsias. This is an area of like dark necrotic tissue at the site where the tick attached and took its blood meal. So presence or absence of an eschar can be an informative piece of information about what type of tick and what pathogen might have been transmitted at that site. But like I mentioned, I think like the prompting is really more about the patient and the exposure, because like the signs and symptoms are fairly nonspecific, right? So you can't. It just needs to be in mind when looking at those. But really, the exposure. What is the person? Are they out gardening? Do they like to hunt? Are they running and hiking? What are their possible exposures? Even thinking about things beyond the patient. So like, do they have a pet that goes outside? I've heard a number of cases where like the person appears to have no outdoor exposure, but really they have like an outdoor cat or dog that probably brought a tick indoors, and they got their infection not in the classic way of outdoor exposure. Time of year, certainly we think of these more commonly in the like late spring to early fall. But even here in Pennsylvania, where we do get a fairly significant winter, we've had plenty of cases that have been acquired much later in the fall into the winter, where you wouldn't normally think like the ticks are most active or around, but it's all about the burden of exposure and where you are. So don't hone in just on the prime season, but certainly more common in the summer. And then we've already commented on geographic region. So you can narrow down possible exposures by where that person's been in the country. Really helpful. And I think we're going to talk about later is timeline of the illness. You want to match the symptoms up with how long the potential exposure occurred. And I think that limits like the possibilities in some ways. And then the last thing, which we don't think about so much in vector-borne and tick-borne diseases, is immune status. People with particular immunosuppressions or, say, like asplenic individuals are at much higher risk for infection and severe infection with some of these organisms. And so I think you do want to consider immune status, even though I would say that's like not one of the more common things we would have considered with tick-borne diseases.
Okay, and then all those things consider when we talk about testing, and we're gonna expand on that. You know, anything else that you can talk about? What should guide the decision on which diagnostic test to order?
Yeah, absolutely. So, as a proponent of diagnostic stewardship, I want to say, recommend we don't just want to order everything, but we do want to think about what are the reasonable possibilities. So you can look at the sort of laboratory data that you can get back on a patient as far as their like white cell count, their platelets, their liver enzymes, and you can sort of start limiting the possibilities. But I think the really what people should be considering is what are the likely pathogens based off of exposure in a geographic region? Is this patient presenting in a way that matches what those organisms are? And then you factor in the timeline of illness, because I think that's probably the most important part in like picking the correct diagnostic test, is really to match the list of organisms with the presentation timeline, and then order the tests that get you answers in that specific window for the patient.
Okay, so when it comes to, can you walk us through like the main diagnostic methods? As like a molecular testing, serology, and microscopy.
Yeah, those are the three main methodologies available. So to start with molecular, this is really finds its greatest utility in the acute phase of disease. So really, patients presenting within 7 days of symptom onset. It doesn't mean that it can't be helpful beyond that window. Certainly, patients that are symptomatic and have a high burden of disease, the molecular methods are still useful beyond the 7 day of symptom period. However, other methods come into play after that 7-day period where it's not the only thing. So its greatest individual utility is early in infection for everything, but it's not universal. And this is where I mentioned at the beginning, like the complexity of diagnostics for these is really interesting. You have these like highly related organisms, and still amongst those groups, the same methodologies are not useful. So for molecular testing, most useful for Anaplasma, Ehrlichia, Borrelia miyamotoi, and then those relapsing fever Borrelias. And the reason that is most of the molecular testing I'm talking about here is from whole blood, and these organisms are found in an abundance in whole blood where they're easily detectable by molecular methods. I would say like next tier, Babesia. It's a really great test. Molecular methods for Babesia perform very well. But not a lot of people have Babesia PCRs available in their lab, and more commonly, they have microscopies. So, what hinders the use of Babesia PCR, I think, is the like guaranteed send out time, and you really want to make that diagnosis more quickly. So, while it performs really well, that might not be the most useful from like a timeline standpoint for patients. And with that, I just want to mention one thing is across all of these, the recommendation is if you suspect someone has a tick-borne disease, you can do the full diagnostic workup, and you should, to confirm what it is. But treatment upfront is really key. So let's just put that out there first. Waiting for a test to come back for multiple days when you think someone has a tick-borne disease is not appropriate. We really need to be treating them early. But to continue for the molecular methods, so the next is arboviruses. This is gets the middling ground. So these are complex. The arboviruses and direct detection from molecular methods, their window is very short. The virus presence viremic window, either in blood or in spinal fluid, is pretty narrow for immunocompetent individuals. But for immunosuppressed individuals that have trouble maybe clearing that virus, the window can be extended. And so the molecular methods are really good in situations where it's, again, early acute infection, short 7-day symptom window, and even better if you suspect that person might be struggling to clear their virus due to an immune status issue. Lyme disease, so Borrelia burgdorferi and Mayonii, not as much utility. So again, I listed Borrelia miyamotoi and relapsing fever Borrelia as like really great, but same genus, not as good. But the burden of Borrelia burgdorferi in blood is really low. It's tough to detect even by highly sensitive molecular methods. In spinal fluid, probably even worse. The one use where it is really good is in joint fluid. So for like Lyme arthritis, there's usually a lot of organism present, and it actually has good performance. But I don't use a lot of molecular methods for the diagnosis of Lyme disease. And then is available, but usually not very helpful for things like rickettsia. These organisms are found in the endothelial cells of blood vessels. They don't really find their way into the bloodstream, and they're very, very tough to detect by molecular methods. Serology, kind of applied in the opposite sense. So this is usually not diagnostic in the acute phase, like less than 7 days of symptoms. You can get useful information setting the baseline of somebody's prior exposures in that shorter window. But really, serology and its reliance on host immune response and antibody production, there's an inherent delay in those antibodies being present. So we think about the use of serology 7 days or more for most of these pathogens. And also, to use that sort of baseline convalescent testing approach, it requires some logistics, right? And people might get treated and they feel better and they don't want to come back. And serology and getting that second sample to confirm what our suspicion might be logistically in the real world, like practically challenging, right? But serology is definitely the gold standard for the diagnosis of Lyme disease. And also the spotted fever group rickettsias, like Rocky Mountain spotted fever. So we just don't have better methods than that, and we live with the fact that it's not great in the most acute window, but really is the standard of diagnostics for those organisms. For arboviruses, I said again, we sort of teeter between molecular and serology. For most immunocompetent individuals, serologic diagnostics are the standard for the arboviruses. They're largely presenting in a way and in a timeline where the antibody production is there, and so we use serology for the sort of post 1 week manifestations of some of those arboviral infections. Anaplasma and Ehrlichia, there are serology tests. Again, they're useful later in the timeline, or when, say, like someone was treated, as I mentioned initially, and they want to come back and figure out exactly what it was. The serology is really useful, but it struggles in the most acute window. And then I would say we order a lot of Babesia serology at our institution, but I would say of all the serologies, it probably has the least diagnostic utility. People can have been exposed before. It's beyond that sort of 1 week period, and most immunocompetent people might generate antibodies, but they actually resolve their Babesia infection. So it might be confusing when they're feeling well and their Babesia antibody positive. So I think much more of an epidemiologically useful serology test, but is ordered and does have some role in places maybe where the patient's presenting later or you don't have access to blood smear, etc. So then lastly, microscopy. So this is really focused around Babesia diagnosis. Peripheral blood smears, thin and thick, are really the gold standard for detection, recognition, identification, and then parasite burdens, right? So percent parasitemia calculation for Babesia. They have historically been used for Anaplasma and Ehrlichia prior to the molecular methods emerging. You can see the morulae of anaplasma in neutrophils. You can see Ehrlichia in monocytes, but the sensitivity is not good enough for me to call it a first-line diagnostic. So there's just not enough cells to look at. Maybe the sensitivity of anaplasma is in the 40s to 70%, depending on what you read for the blood smear. Sensitivity for Ehrlichia can be really low, like in the single digits. There's just not enough monocytes to look at to really be confident and rule somebody out. Interestingly, you can see the relapsing fever Borrelias on peripheral blood smear. So this is, again, a big difference between the Lyme disease causing ones and the relapsing fever. These Borrelia that cause relapsing fever, they're in high burden in blood, and you can actually see them on peripheral blood smear, but again, not the first line diagnostics. And then microscopy is really not useful for anything else that I list. Obviously not the viruses, but not for any of the Lyme disease causing Borrelia. They just do not get to a level in peripheral blood where you can visualize them.
Okay, and by now you have mentioned, you have talked a little bit about timing, and I'm just want to kind of, ask this question to reemphasize this. And why is the timing, between the symptom onset and specimen collection important for test accuracy?
Yeah, I think it's twofold, right? You want to order tests that are going to give you useful information. And so if you have a patient presenting early and you only order serology testing, for example, it's unlikely that that's going to be positive. And if it is, it might actually indicate a prior exposure. Um, so you really, I think that the risk there is for people misinterpreting the results. So if they don't understand the timeline of disease and the expectation of test performance based on that timeline, they may look at a negative result and rule out an infection that's totally plausible. But the method they use to try to diagnose it is tricking them into thinking it's not real. And the same goes for the molecular methods, right? If it's really late in sort of a course and people are generally recovering and you try to use one of those, it's not going to give you the information. So the key here is there's transient nature of some of the organisms, there's host response involvement. And in order to order appropriately and then interpret appropriately, you really need to understand the sort of life cycle of what's happening across that time.
Okay. When it comes to Lyme disease, I wanted to ask you, there's this modified two-tier algorithm. So maybe you can talk about that, and how does this approach, improve diagnosis, and anything that the labs should keep in mind when it comes to this?
Yeah, so a number of years ago, there was an update to the standard two-tiered testing algorithm, which was a screening EIA ELISA and then a follow-up Western blot in the oldest version, but then immunoblots in the newer versions. So the update to the modified algorithm is that it's 2 successive EIAs, no more immunoblot or Western blot confirmation test, using basically 2 similar but different antigen preparation tests in succession. The advantages of that are multifactorial. So one is that in the acute phase of Lyme disease, there's an increased sensitivity, and about 10% or so over the standard 2-test algorithm. So using these 2 EIAs better is capturing more people in the earlier phase of their Lyme disease infection. Still not perfect. The sensitivity that I'm referencing is, between 40 and 60%, depending on where you look. So not a perfect early acute Lyme disease test, but better than the prior algorithmic version. That's also, I should mention that that performance benefit did not come at the cost of any other performance. So still has the basically exact same performance in later Lyme disease manifestations as the standard algorithm, still has the same specificity performance as that prior algorithm. So we're not compromising in any way in other areas. We're just incrementally gaining on that acute phase diagnostic part. A nuanced detail is there's a broader inclusion of the antigen preparation that reaches more of the Lyme disease causing Borrelia than the original versions, which were very Borrelia burgdorferi specific strain. I can't remember specific. So they're a little bit better at detecting the other Borrelias that cause Lyme disease. And then the last piece, I think, and this sort of gets a little bit to the lab part, I think, is doing these 2 EIAs in succession. They're both usually automated. They have a binary sort of output. There's no subjective interpretation of a Western blot or an immunoblot where technologists are arguing over if the band's present or not, if the dot's present or not. And so it removes all that subjectivity. So I think that's really nice from a workflow standpoint when you're not compromising performance, is to get something that is really, dictates its output and there's no debate. The disadvantages, though, kind of relate to what I just mentioned. So in the Western blot immunoblot version, there were, a number of antigens in the components, 3 IgM antigens, 10 IgG antigens, and you could use those responsibly to investigate if someone maybe had reinfection, right? You could see expansion sometimes. Maybe someone started with 5 of, or 3, 4, 5 of the antigen or bands positive, and then they get reinfected, and now their antibodies expand and they're back up to 10 of the antigen antibody combinations present. You can't do that in the new method. The 2 EIAs are just positive or negative. If you've been previously infected, you maintain that positivity for quite some extended period of time. If you get reinfected, the result doesn't look any different. So we've lost a little bit of the interpretive nuance that the Western blot or the immunoblot allowed. And then another disadvantage, which is a disadvantage across all of the options, is you can't use the serologic methods to monitor response to infection. Whether this was the standard method or the modified method, that's just something you can't do using this type of assay. So I think labs need to keep those challenges in mind when they're talking to clinicians that want advice or interpretation, or they have a tough case or a tough patient and they really can't figure out, is this a reinfection? Is it prior result? That there's limitations to switching to the modified method, but I certainly think the advantages outweigh them.
Okay. So, one thing when you mention about Babesia and you talk about when we're talking about like microscopy and things like that. When it comes to detecting it and are there any maybe challenges to it? I know, like especially when it comes to maybe with microscopy, that can be a skill that's acquired over a long time, and maybe we all have issues in the lab with training, and sometimes people retire and getting people to that level again and things like that. So maybe you can talk more about that. Maybe when it comes to, are there any challenges when it comes to that?
Yeah, absolutely. I think you're nailing the sort of microcosm of the challenges we're going to face across medical laboratory science and labs in lots of areas, and parasitology and Babesia testing is a perfect example, right? A lot of laboratories have been challenged to maintain the expertise. It is absolutely a skill to perform most of the parasitology testing that we do. Ova and parasite exams from stool, blood parasite smears for malaria and Babesia. So for Babesia, I mentioned the ideal diagnostic, I think, because it's low resource, it's quick, and it can be done locally is blood films. But making those, staining those, and reading those is not insignificant. And thinking about trying to do it 24/7 if you really want to provide, around the clock access, that's really really tough. With retirement and people moving on to other and different positions, getting promoted, etc., we've experienced um, the loss and the rebuilding of some of our parasitologists here, and they're fantastic at this now. But it's taken years to get them to where they are. So I do think that one of the main challenges with the Babesia diagnostics is that depending on where you are in the country, you may get a lot or a little of Babesia. It might be really tough to maintain scale and competency over time, and it is an art. And I think it's one as we're seeing that um, is with the sort of a new adoption of slide scanning and AI technology, is that this is something when you're up against that challenge and you're debating, do I put my limited resources into training a really highly skilled parasitologist, or do I have them do any number of the other things that the laboratory needs people to do? Maybe you're starting to think it's hard to maintain, and people pass. Um, the other diagnostic approaches I mentioned, serology, does is useful in the later phases, but it's really not a good acute phase diagnostic option for Babesia. I think the new player in this game is Babesia PCR. There's no FDA approved, to my knowledge, Babesia PCR, but a number of places offer it. In the reference lab, though, realm, sending out some of your tick-borne testing is really slow, and it depresses the clinical value and the impact on the patient when you do that. While it's a great test, again, it hasn't really found its perfect fit in the diagnostic workup. So I think that Babesia, of all of the organisms we're talking about, is sort of the most challenging diagnostically. There's no perfect method that fits the modern lab, and it really is easy from a maintenance and skill perspective.
Okay. And you mentioned AI, and I'm gonna definitely ask about that in a little bit. And emerging technologies and things like that. But before I ask that, I know, like, you mentioned Borrelia Miyamoto, and it's also like the Asian longhorn tick. I mean, are these lesser known? I mean, as I said, I normally don't have too much exposure to these. So are they lesser known? And if so, is there anything that labs and clinicians should know about them?
Yeah. Among the organisms we're talking about, and the ticks that we've mentioned, like Ixodes and Amblyoma, these are certainly lesser known. So for Borrelia miyamotoi, I think what contributes to that is we lack sufficient access to testing. Testing for that is not very common. Most people probably are not considering it all of the time. We talked about the fact that, we don't want to withhold treatment from anyone we think has a tick-borne illness. And doxycycline is the treatment of choice for Borrelia miyamotoi. So I think one of the other things is that we might do a broad workup that doesn't include this organism, and it's all negative, but you treat somebody with doxycycline and they get better. So the investigation ends because they're back to their normal baseline. So I think in some sense, we just don't get down the list far enough. And it might have been Borrelia miyamotoi, but because the person's feeling better, we're not going to come back and do more testing. So, um, but there are specific PCRs and serologic tests for this entity. So I think if people, practicing in the Northeast and they have a patient that doesn't have sort of the routine organisms that they regularly test for, testing for Borrelia miyamotoi is reasonable. And I think one thing that contributes again to us not you only know a lot about the things you look for, and the fact that we're not looking for Borrelia miyamotoi very often is probably the reason we don't diagnose it clinically. We know epidemiologically from tick surveys and prevalence among individuals just from the epi screening portion that there is a reasonably substantial amount of Borrelia miyamotoi in the Northeast and the Upper Midwest. So I think it's just under recognized and underdiagnosed. And if we get to the topic of where the future goes, I think we'll start learning more as we look for it more. The emergence of the Asian longhorn tick is really interesting. Um, there's a lot of data, mostly research focused, that says that this tick is competent to harbor and potentially transmit lots of the organisms that we regularly think of in other tick species. So the thing I think we should know is that this is just another vector that is out around, and if you're exposed to it, it gives you the potential to get some of these tick-borne diseases. I think really interesting in some of the new data coming out about this tick is it's competent potentially for lots of the tick-borne diseases, maybe even more than the ixodes. Whether or not it actually works that way in nature and transmission is common is another story, but the potential is there to add to the list of vectors. I think anytime, though, you get a new vector introduced from another part of the world, you also run the risk of importing pathogens. So at least I would say this is a fear. I don't know that there's any evidence that it's true, but in Asia, in China specifically, this tick transmits severe fever with thrombocytopenia syndrome virus (SFTSV). Um, which causes a hemorrhagic fever. It transmits a rickettsia species called Rickettsia japonica. So theoretically, however that tick is introduced, it could bring pathogens with it. And then if there are environmental reservoirs and hosts that can continue that life cycle, there is the theoretical fear of introducing new pathogens to a part of the world where they were not formerly present. So I think those are the things people need to be just aware of, because they're possibilities.
One thing that we see definitely, it's in the lab, and this is something we have talked in the podcast, and testing has definitely changed over the years, and a lot of us like in the lab and bacteriology, things like moldy and how things have changed, and we definitely so there's no all across the lab we have seen testing change. So when it comes to tick-borne diseases, how do you see it, evolving over the next few years? And if there's maybe like a key message that you hope labs and clinicians take away from this conversation?
Yeah, I think with a better understanding of the performance of the tools available to us, one really great place to focus over the short term is diagnostic stewardship. So I think that um, I think that putting together panels that help people choose the right test is something anyone can really work on, right? There's a large number of diagnostics available. The timeline, the patient information, it all factors into what are the best diagnostics. It's a lot to keep up with and to expect, many of these patients are probably presenting most often in the ED or their primary care physician. They're not presenting just to an ID clinician that might be hyper aware of all of the test performance and diagnostics. We need to find ways to put the options in front of people that are most likely to help them. I think that can be done just simply through clinical decision support panels and asking a couple questions that can really help guide a clinician to the most appropriate tests. I think in a way that the best thing is really to make sure we're not missing a test that would be useful, and then the next best thing is to try to eliminate the ones that are wasteful, right? So get the patient the best test at the right time, and then maybe if they really don't, they're presenting very early and a Babesia serology in this timeline is not helpful. Maybe we can eliminate a little bit of the lower utility tests. So I think that's the first part is ordering panels or ordering pathways. But then I think the thing that is probably going to come in the next few years, we've seen these in the LDT space already, and there's evidence around sort of multiplex testing for tick-borne diseases. Um, So this would be like something new in the next few years, specifically, of course, for pathogens where PCR is useful, right? So Anaplasma ehrlichia, maybe Babesia, if you no longer have the ability to do blood parasite smear, but you could bring in a quick, easy in-house Babesia PCR. Maybe we could flip the algorithm on that, using that as like the screening tool, and then actually just doing blood parasite smears on the positive ones. Borrelia miyamotoi. The list, is a little bit longer probably, but I think from what we've seen in the syndromic panel world, this is access to testing is really valuable. The way to get that testing in people's hands is to put it together in a package that can be put in a cartridge and run on an instrument. So I think from the innovation standpoint in the short term, I think there's room for a multiplexed tick-borne type panel. But we've talked already about all the nuances, so putting those together is really complicated.
Yeah. And one thing that when it comes to testing, and you touched a little bit on it earlier, and this is something that we have talked about when it comes to AI and things like that. With emerging technologies, and we know that sometimes like AI has been used, and I, you mentioned Dr. Britt, and I had her on where they had like developed an AI program where they were like looking at some smears, and then it was kind of like ruling out all the negatives, and that kind of frees the tech to do spend more time on other tasks or focusing on other things, so making eliminating things like fatigue and stuff like that. We also see things like metagenomic sequencing. And so how do you see all these emerging technologies fitting into the future of tick-borne disease testing?
Yeah, I mean, the one that's farthest along is certainly the AI applications. And I think blood film screening by software is a perfect place for us to be deploying, starting, and hopefully it grows. You can certainly see the advantage where like you can get through a significant amount of volume that doing manually is just unapproachable or requires too many people to do. We've already talked about the maintenance of the skill part, and as you mentioned, if you're getting rid of the low value ones for people to look at, and then they're just looking at the positive ones or the questionably positive ones, they're seeing a lot more of the the organism and the pathogen, and maybe it's easier for them to maintain their skill because that repetition is a little bit higher. But certainly you can train somebody to do the um, that lower volume part and then have them doing something else while the AI is getting rid of all the low value stuff for them that they don't have to look at. Um, and then I think that additional time savings. We're always asked to find new efficiencies, and be able to use our time and resources more wisely. And I think the AI applications again are perfect for that. So I think, and we'll certainly be seeing the microscopy portion move more towards the slide scanning AI tool, and have those things help us do our job better. I think the other area is to capitalize on some of these pathogen agnostic advanced molecular methods, so sequencing based methods or metagenomic based methods. When I was a fellow, I worked on a blood based tick-borne targeted next gen sequencing assay, sort of like if you're familiar with broad range PCR and the way we use it from tissues and fluids and formalin fixed samples. You can do the same thing from blood, and for the organisms that have high burden, you can detect them really well. So I do think as like sequencing becomes more approachable, it's simplified, maybe it's in a box, and cheaper. We could approach the idea of multiplexing instead of multiplexing multiple PCRs together. Why don't we multiplex in the way of like, let's use a method that's actually or pathogen agnostic, and we could use metagenomics to capture or look for many different types of pathogens at once. The advantage here, in the dream scenario, is that we know people have summer febrile, likely tick-borne illnesses that we don't get an answer for. So maybe we'll see the emergence of new pathogens. I think that's a little bit of a dream. There's probably not like a ton of pathogens we haven't recognized, but we have seen over the last couple of years recognition of Borrelia miyamotoi more often. Borrelia mayonii as a Lyme disease causing Borrelia. The viruses, the arbovirus that we're seeing new ones every once in a while. So I think there's the possibility that an agnostic method like metagenomics could detect new pathogens. But I think in the greater sense, if it is cheap and fast and easy, that the highly multiplexed nature of it, really for the fact that we can test for a lot of things at once, and also it eliminates the need we've talked about already for everyone to know what the risks are and test for all of the things that are appropriate. An agnostic method eliminates a little bit of that and can test for things without a lot of understanding or thought behind what is the exact pathogen I'm looking for.
Okay. Well, this has been such a great episode, and I hope the audience, enjoys it as well. And I'm gonna end up with a question, which is meant to end on a lighter note. Before that, I want to thank you for doing this, and something that you said at the beginning, and I think I really identify with that. You start as a medical lab scientist, and then sometimes, we do get that feeling in our careers that maybe we can do something else, we can do something different, and that's very true. Some people are just happy working the bench for 30 years, and then, that is great. It's such an important job, but there are some out there, so I really identify with that. I did start feeling that in my career, hence, what I'm sitting here talking to you, and have talked to many people. So it's definitely great. You have that feeling that you can contribute in other ways. Um, but so before I ask my last question, is there anything? Do you have any closing thoughts when it comes to this, to the tick-borne disease, or anything else that you want to tell the audience about?
I hope people find the tick-borne diseases and vector-borne diseases in general really, really interesting. I think they're, not the most common of organisms, and we think more about cultures and we think more about classical microbiology organisms, but these more atypical bacterial pathogens, viruses, parasites, it all the subspecialties of microbiology exist within this realm of tick-borne diseases. So hopefully, this podcast has excited some people to learn more about tick-borne diseases and really investigate them, because I think they're really understudied and really important components of the pathogens we look at. And then I guess the last thing I want to say is thank you to you for having me on. And what you mentioned, like wanting to do something else and give back to the community or add something to the community. I think you doing this podcast is a really amazing way to talk about medical microbiology in a way that people can relate to and easily learn from. And we're always looking for ways to engage the community with our field as sort of a hidden component, but very valuable piece. And I just really appreciate that you've created this platform. So great job.
Oh, thank you so much. Well, definitely a pleasure having you. And as I said it before, I do. This is something that I enjoyed, and I'm very grateful for the listeners. But I still maintain this, even if no one listen, I will still be publishing things. This is just a wonderful process that I enjoy, and what I have gained from it, it's such a plus. So even if there were no listeners, but thank you for those of you do. I really love you. I appreciate you, and please continue listening. Okay. Um, you know, and just something real quick to wrap up, because you mentioned that, and that's something, and you can just touch on this very lightly, but you mentioned, them being understudied, and is there like do you have any thoughts on that? I know that definitely, right, bacteria gets a lot of the spotlight, and antibiotics, and antibiotic resistance, it's like a huge chunk of the spotlight. Is there anything? Why are they tend to be understudied? And this can be quick, or I can, yeah.
Yeah, that's a great question. I think part of it has to do with the sort of ease of treatment. I've mentioned a few times that you can treat preemptively, largely except for Babesia. The treatment is doxycycline, so you cure a lot of people relatively quickly, without a lot of fancy antimicrobial resistance and nuance in the decision of therapy. For the viruses, for most of them, there's no direct therapy. There's just supportive care. So I think, unfortunately, because of those, it lacks a little bit of energy around the investment in that field. Diagnostically, I think it's pretty similar. We haven't seen anything unique or really new in the diagnostic realm, probably because the perspective on that is that is that the diagnostics don't play the same level of role as they do in other infections, or that they're not as common or widespread for the number of individuals that you would be testing than other infections. So there's just, I think, a lot against development and innovation and investment in tick-borne diseases, and that contributes to us ultimately not recognizing them as much.
Okay. Well, thank you for that. Okay, so I thought we will wrap up on on a lighter note. We have delivered the audience such great information that I hope they enjoy. And so this question, I always like finding out the answers and what the guest thing. And we all tend to have that favorite bug, that favorite organism. Either has that significance. Maybe you work with it in school, or could be anything as a visual or a mechanism. There's so many reasons that we all tend to have our favorite bug or our least favorite one, which is also a fair answer. So, Dr. Rodino, what is your favorite bug?
Yeah, great question. Anyone who knows me knows how I'm going to answer this. So my favorite bug is Echinococcus. I think it's the coolest parasite there is. Its life cycle is so interesting. Diagnostically seeing it from like a liver aspirate and recognizing the protoscolices and scolexes and the appearance of all its, armed rostellum, and it's just like the most horror movie type organism I can think of. It just makes it very, very interesting to me. Recently wrote a case in the newly released cases in medical microbiology and infectious disease group, and I got to write the Echinococcus case, which I was very excited about. And one of the coolest facts I think about Echinococcus is that its hooklets are acid fast. So if you're lucky enough to get a surge path or cytology specimen and you stain it with like a Phyt Faraco stain or an AFP stain, those hooklets, they light up pink. And I haven't seen a lot of examples of that, even though it's a known fact in the literature. So there's a picture in there showing that appearance. And I think that organism is fascinating and scary, and one of the ones I like to teach and talk about to like medical students and college students, etc., because they think it's fascinating, and it really hooks them on the on medical microbiology and parasitology.
Okay, wow, such a great answer. So, thank you for sharing that. And for the listeners, as I said, I will put the link to the mini review on the show notes so you can enjoy it. So once again, Dr. Reno, what a pleasure. So thank you so much for taking the time to be in Let's Talk Micro.
Yeah, thank you.
My pleasure. Well, there you have it. I hope you enjoyed another great episode. Such great content. So thank you, Dr. Rodino, for joining us on the podcast and talking about tick-borne diseases. Well, thank you for listening. And as always, you can find us on any podcast platform. So if you go to Apple, Amazon Music, Goodpod, Spotify, you can find us right there. So I invite you to subscribe to the podcast, download episodes, and if the app allows you to do so, please go ahead and leave a review. I invite you to follow us on socials. So we are on Instagram, TikTok, Blue Sky Social, and YouTube as Let's Talk Micro, on X as Let's Talk Micro 1, LinkedIn as Luis Plaza, and there's an email address which is letstalkmicro@outlook.com. And there's also the website, which is letstalkmicro.com, where you can find study resources, licensing requirements, episode updates, and more. So I also invite you to subscribe to the website. So as always, thank you for the support. And if you have any feedback, any topic suggestions, you can definitely submit those via email or via socials. Once again, thanks. If you want to support us in any way, you can do so via Venmo or via Buy Me a Coffee, KOFI, both links available on the show notes. If you're looking to learn more about antibiotics, please check out www.learnantibiotics.com and the Learn Antibiotics book, available on Amazon. These resources include cheat sheets, practice tests, games, and more, and they are being used by thousands of people worldwide and may be helpful for you or your colleagues. As always, these are some great resources from Dr. Timothy Gauthier, a very passionate pharmacist. And as you know, the Let's Talk Micro podcast is supported by the American Society for Microbiology. To learn more about microbes, visit asm.org. And that, my dear micro friends, it's the end of this episode. I hope you enjoy learning about tick-borne diseases, about diagnostics, and more. As always, I enjoy sharing this information with you. Thank you for the support. Stay tuned. Great things coming your way. Great content. So I appreciate you. As always, continue bringing that passion to what you do. It's so important. You do such great work. And as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time. Bye.